Okay, so this is an interesting case. As you guys saw the previous video, I called it the opposable thumb. He's got the reverse of the typical bunion. His big toe is drifting. He's got discomfort right around the knuckle because of the dislocation. When you see him stand, his foot is completely skewed, and it's unfortunate. So he's using the big toe as a stabilizer rather than a propeller. And so what I need to do is assess the ankle motion, which was stiff with both knees, both the knee bent as flexed or versus extended, which would require a tendo Achilles lengthening rather than just a gastric recession, which in this situation will not require. So he also need to address this bump. So when he stands, his foot goes, relax your foot if I may. Yeah, just relax your foot. So when he stands, his big toe is in line with the shin bone. As we can see, it should be second toe to shin, second toe to the kneecap. So when he stands, when he stands, it just likes to want to escape or bulge out or pronate at the ankle area. And we see this prominence, the prominence which is this little big eminence on the bone. So that needs to be addressed. That's part of the navicular. Relax your foot for a sec. So what I need to do is this little guy, shave that down, bring the tendon back up where it should be. So pulling this instep with two anchors, dissolvable anchors, so that little nipple, if I may use, or protrusion needs to be shaved down and bring the tendon back where it should be, transposing the tendon to pull the arch better. Now we know on the side, we can note the extent. So what I usually do, the landmarks are the peroneal tendon, the sinus tarsi, and the calcaneocuboid joint. So we make a little incision on this side, and you reflect the tissue that needs to be. You got to pull a little bit off the tendon, but not damage the tendons, and break the heel and put a wedge, a cadaver bone. And then furthermore, sometimes what I do, which is very rare, in his situation might be as well, also putting a wedge into the cuboid to bring it forward. Because when you guys look at the x-rays and when you see him stand, you'll agree with what I'm talking about. Then now we got to address the forefoot. So when you look at the front of the foot, we can see the bone, the big toe is obviously drifted. But if I do this, you guys can see this bone is too close to that. And it's too long. So the knuckle, in comparison, if I may, is the bone right here versus that bone is way too long. And so what I'd like to do with this is, typically what I do is take a wedge of bone. What I usually do is pin this bone to that bone, and so it doesn't vibrate, and take a shape of a bone in a trapezoid and push the thing back and put a staple in a staple, and that should hold it well. And then I would bring a little tiny anchor to stabilize that more so and create more stability along this side. I'll lower the bone a little bit and drift it a little bit, not much though, because everything is going to be pushed in. So we can't push it too much in. So, and that's what we need to do. So this is fairly hard to correct. He is in his 30s, and it's unfortunate. You can see how pliable it is. So it wants to go that way. But we'll correct everything, but we have to address the foundation before we address this. And so that is a tutorial in regards to my colleagues that address the patient's symptom rather than the deformity as a whole. By fixing this without fixing that, it will not work. And I can assure you, because once you guys see him stand, please come on, stand for a sec. Stand normal, face her if you could. And now we can see how the big toe wants to hold onto the ground and stabilize. Now, if you can turn around, face me. We can see the heel and the curvature and the bowing. So the bowing of this Achilles, the heel rotation, the forefoot going that way. So you guys should not be seeing all these toes from the rear. It should be more in line, and this should not be rolling in. So hold on to me. Yeah, lift up your foot. Lay it flat. Hold on, lift up. I'm gonna rotate your heel slightly. Yeah, and so that's where, so relax your foot slightly down. That's where it should be. So heel to toe should be the second toe to shin, and that's what we're going to try to accomplish. The bones of the ankle should be in alignment, the arches should be elevated, and that's what we need to address. And also, we can then address the big toe at the same token. And so that's what we're doing. Thank you. At is these bones, which if I can point to them, the way they're pointed should be more straight towards 12 o'clock. Should not be pointing that way. So what we need to do is address this and address this whole curvature should be aligned. The other thing is we're going to shave that as we discussed and bring the tendon into it and to pull better, to bring the whole structure back in. Then we're going to evaluate how much of a space in between, because we're going to bring the foot inwards, and we're going to decide how much of a correction of this and this bone called the intermetatarsal angle. Second, we're going to address the length of the bone, and that's when I said we pin. I try to pin this to that, so therefore it doesn't vibrate, so I can take a wedge and it doesn't interfere, so it's easier, it's a clean cut, and then so therefore I can take the pin and I can bring it down and then repin it in a different area and staple it versus a plate if I require, or a screw. So here is the symptoms that he was describing, because the toes keep going outwards. So yes, that will be brought back into play and will be tightened if I have to use little anchors. They do have also, this is called the hallux varus, just congenital, but I think it's more so the foot type as a whole is kind of skewed, going this way, going that way, going this way, and that all structurally has to be sound. And then we're going to address the forefoot. So by just fixing this without fixing this, I don't think that would be helpful to the patient, because the load will continue and that will create further problems, and you will, whatever you do, breaking bones or realigning, will rip it back to pieces, because the alignment and the correction has not been corrected from the rear. So anyway, so I hope this was helpful. Thank you very much. Okay, face me, come on towards me. Yeah, now turn around, please. Keep going. Okay. Okay, stop. One more try. Okay, turn around, just turn around. Stay like that, please stop. Yeah, try to march up and down where you are. Just don't walk.
Oh. Want to turn around too?
No.
Okay.
Stop. So that's how you feel. You like it straighter that way, right? Or you, because before you were not like that.
I know.
Can you do it again, please?
What, this?
Yeah, up and down. Yeah. Okay, face me, please. Turn sideways that way. Again, turn the other way. Okay.